Hi everyone, welcome to our ninth and last lecture on neuropsychology and psychopathology. This is our final lecture, and so in this pre-recording, I will give you an overview of the most important facts in chapters 15 and 16 of our textbook. For detailed information, please attend my last lecture in person. I shall start with neuropsychology. What is neuropsychology? Neuropsychology studies the link between brain dysfunction and behavior cognition. It is a specialized field within clinical psychology that seeks to understand and treat patients with cognitive impairments resulting from aging, disease, injury, etc. Who are the neuropsychologists? Generally speaking, they are licensed doctor-level clinical psychologists who completed specialized training. They often work in collaboration with neurologists. Neuropsychologists assess and treat cognitive consequences of injury or disease. On the other hand, neurologists, they are medical doctors who assess and treat physical consequences of injury or disease. Neuropsychological assessment relates to different goals. Choice of methods depends on the conditions involved, and normally standardized psychometric tests are the norm. Such tests involve comparisons with general population, comparisons with abilities unaffected by condition, IQ tests, and we have a very famous test battery called the NRMB. And condition might affect test performance, right, such as pain, fatigue, medications. Neuropsychological testing, here is one example of a very famous test we call trail making test. It assesses motor speed, visual search, processing speed, and mental flexibility and executive functioning. Neurocognitive disorders are described in DSM-5. They refer to when a patient experiences a decline in functioning in one or more cognitive domains after a known challenge to the nervous system. The bullet points show the following examples of important cognitive components. Now we look at dementia, which is an umbrella term referring to the gradual loss of cognitive functioning interfering with a person's daily life and activities. It is more than what would you expect based on normal aging. So, such as not being able to remember how to get home. This happens in the early stages of dementia. And not knowing what day or year it is. It gets more severe as it progresses. Difficulty with planning, grocery shopping, changes in behavior, inappropriate behavior, change in personality. This happens in the most severe cases of dementia. And here is a glossary of the most important aspects of Alzheimer's disease, which is the most common type of dementia. Alzheimer's disease risk increases with age, and it usually happens with mild memory loss, also referred to as MCI, leading on to higher order cognitive impairments during late onset AD. Probable AD is diagnosed on the basis of genetic testing, family history, clear evidence of learning and memory impairments, steady gradual loss of cognitive functioning without plateaus. While on the other hand, confirmatory AD diagnosis requires PET and brain autopsy. On this slide, we shall focus on the APOE gene, specifically the epsilon 4 variant of the APOE gene. The APOE gene is responsible for lipid transport, and people with one epsilon 4 allele are 3 times more likely to develop AD than people without any epsilon 4 allele. People with 2 epsilon 4 alleles are 15 times more likely to develop AD than people without any epsilon 4 allele. Exercise, surprisingly, had non-significant effect on risk for AD for people with epsilon 4 alleles, while on the other hand, APOE epsilon 2 alleles can offer some protective effects against AD. And AD can also be inherited due to mutations on the APP gene, PSEN1 gene, and or PSEN2 gene. Importantly, AD involves the atrophy of the cerebral cortex and neural degeneration. So there are two abnormal protein structures found in people with AD. They refer to neurofibrillary tangles and beta amyloid plaques. Please remember these two kinds of abnormal proteins. And here is a brain image of people with advanced AD. Compared to normal individuals without AD, you get to see a deepening of cell size and a very prominent enlargement of ventricles. So what are the treatments for AD? Currently, what we do know is that approved treatments slow down but do not reverse the course of the disease. And importantly, the use of monoclonal antibody drugs targeting beta amyloid tend to clear plaques. And an example of such a new drug is called Aduhelm, also called aducanumab. Please click on the URL to have an overview of this drug. The side effects of this drug relates to brain aneurysm, so it is not really highly recommended. There are also the use of acetylcholinesterase inhibitors and the use of non-medical approaches through diet, exercise, and lastly, there's also the use of antipsychotics, which is associated with earlier death. So this kind of treatment is no good as well. A stroke occurs when the brain's blood supply is interrupted by either a cerebral hemorrhage, leading to hypertension and aneurysms, or the sudden blockage of a blood vessel, which can result in ischemia, infarct, TIA, thrombosis, or embolism. Within the 24 hours after a stroke, excess glutamate tends to be released into CSF, producing neural damage through excitotoxicity. Neuronal cell death occurs immediately after a stroke, but prompt medical attention can save the neurons and glia in the penumbra, which refers to the region of the brain surrounding the core region that is suffering an infarct. So we have the use of drugs, reducing blood clotting. We can use mechanical devices, drugs like HDAC inhibitors, surgery, and physical activity. Now let's look at psychopathology. What does it mean to have a mental disorder? According to DSM-5, a mental disorder is a syndrome characterized by clinically significant disturbance in an individual's cognition, emotion regulation, or behavior that reflects a dysfunction in the psychological, biological, or developmental processes underlying mental functioning. Investigations of mental disorders tend to focus on biological correlates or markers that support biological treatments. Here we look at a diagram showing early influences on the gut microbiota. This diagram shows an interaction between prenatal factors and postnatal factors. Prenatal factors have genetics as the primary factor, while for postnatal factors, we look at delivery method, we look at feeding method, the use of pre-probiotic supplements, and at the intersection between these two factors, there is environmental factors such as physical stress, and maternal stress, nutrition, medication, etc. Mental disorders, MDs, are common. It happens 1 in 2 Australians, and it happens in 1 in 5 Australians within the last 12 months. In the following slides, I want everybody to focus on 5 MDs, starting with ASD and ending with schizophrenia. Let's start with ASD, autism spectrum disorder. It is a neurodevelopmental disorder with deficits in 2 behavioral domains. The first is social communication, interaction, and the second is a bit similar to OCD, showing restricted, repetitive patterns of behavior, interests, or activities. Like dementia, it is an umbrella term. And the spectrum recognizes that the disorder varies widely from individual to individual. When you have time, please watch the YouTube video. When it comes to ASD, many children make relatively normal adjustments, but up to 60% can be intellectually disabled. ASD is 4 times more prevalent in males than in females, and its diagnosis have been increasing over the years. 1 in 70 in 2018 versus 1 out of 100 in 2014. This could be due to rise in incidence relaxation of diagnostic criteria or both. This slide shows the increasing rates of ASD from 2000 until the year 2010. Now let's look at the brain structure and function in ASD. Brain development is abnormally accelerated through early childhood, producing first brain enlargement followed by a period of deceleration. On the next slide, we shall look at differences in the structure of mini-columns from non-ASDs. There are also differences in sizes of amygdala, hippocampus, cerebellum. ASDs tend to have smaller amygdala and cerebellum, but larger right hippocampus compared with non-ASDs. And the DMN also tends to be disrupted. There are also dysfunctions in mirror systems, which is a bit controversial. This slide shows you mini-column differences in ASDs versus non-ASDs. Compared with non-ASDs, ASDs exhibit reduced distance between mini-columns of neurons in the PFC. Such findings ties well with the notion that ASD savants favor highly detailed local processing over global processing. ASD is usually treated with intensive early childhood learning experiences provided during most of the child's waking hours. Medications intended for alleviating core behavioral problems have generally found to be ineffective or to have severe side effects. Hence, medications are generally no good. Probably, APA, applied behavioral analysis, is the best approach. It is a kind of therapy that makes use of operant conditioning. Lastly, research does not support gluten and casein-free diets for ASD individuals. Now we turn to ADHD, attention deficit hyperactivity disorder. Like ASD, it is a neurodevelopmental disorder. It is the most common psychological disorder in children. It is characterized by inattentiveness, impulsivity, and/or hyperactivity. Based on its DSM-5 definition, ASD must interfere with or reduce the quality of social, academic, or occupational functioning. Now we look at the brain structure and function in ADHD. ADHDs experience delayed maturation in the PFC, ACC, caudate nucleus, and connections between these regions. They also tend to have smaller volume in amygdala, basal ganglia, hippocampus, compared with non-ADHDs. But such volumetric differences can disappear during adolescence as the brain matures in ADHDs. Lastly, ADHDs experience disruptions in DMN. ADHD is generally treated with Ritalin, Adderall, which are dopamine agonists. They can confer side effects such as loss of appetite, sleep disturbance. Non-stimulant drugs are also available, but they are associated with increase in suicidal thoughts. Antipsychotic medications were also prescribed in spite of the antagonism of dopamine activity, which is highly surprising. Now we look at major depressive disorder, MDD. MDD relates to periods of pervasive sadness that last for at least 2 weeks. It affects around 7% of the adult population every year. It affects women more than men, and its prevalence rates decrease with increasing age, with women still outnumbering men in older age. This slide shows you age and sex differences in rates of depression. Note that the rates of depression decline over the years, but women still outnumber men in all age groups. Genetic contributions to MDD. Heritability plays a moderate role, and many genes are also implicated in MDD. Specifically, they focus on the neurochemical serotonin pertaining to its reuptake and transportation. Please remember this. As for brain structure and function in MDD, MDDs generally have reduced volumes in the hippocampus and amygdala and larger lateral ventricles than non-MDDs. And damage to the left frontal lobe resulting from a stroke can produce a profound depression. Functionally speaking, there is reduced left frontal activity, reduced right parietal lobe activity. However, there is increased right frontal lobe activity relative to non-MDDs. There are also correlations between sleep patterns and depressed mood. This slide shows you how depression is associated with abnormal patterns of sleep. MDD fall asleep much faster, enters REM much faster, and spends almost no time in NREM stages 3 and 4. In the treatment of MDD, SSRIs are the most commonly used. There is also CBT, aerobic exercise, ECT, rTMS, and DBS. Now we turn to bipolar disorder, which is described as a bridge between the psychotic disorders and depressive disorders. It is characterized by at least one lifetime episode of mania and is often preceded or followed by a period of depression. So there is bipolar 1 and bipolar 2. Specifically, bipolar 2 is not as severe as bipolar 1. It does not involve full episodes of mania. And bipolar disorder has also been linked to enhanced creativity, and women are more likely to get bipolar disorder than men. Individuals with bipolar disorder tend to have similar brain structure abnormalities as in schizophrenia. However, unlike schizophrenia, they have larger than normal intracranial volume. Bipolar disorder is related to oxidative stress, and it can be treated using lithium salts, SSRIs, benzodiazepines, which serve as sedatives. Diet may influence the prevalence of bipolar disorder. Specifically, omega-3 fatty acids from fish and other seafood may offer good protection against bipolar disorder. We now turn to schizophrenia. A diagnosis of schizophrenia requires at least 2 of the following to be present most of the time during a single 1-month period. Positive symptoms cover delusions, hallucinations, while negative symptoms cover diminished emotional expression and avolition. Schizophrenia occurs in 7 to 10 cases per 1,000. About 60% are male. It is typically diagnosed between 18 and 25 years of age. The concordance rates of schizophrenia are about 50% in identical twins. There are also genes for schizophrenia that overlap with those implicated in bipolar disorder. Abnormal saccades may be an important behavioral marker of schizophrenia. When it comes to abnormal eye saccades, schizophrenics tend to commit more of such errors than non-schizophrenics. The environmental factors can also interact with genetic vulnerability. The rates of schizophrenia are somewhat higher in urban environments. They're also 5 times higher in lower SES than in higher SES groups. Prenatal environmental factors such as vitamin D deficiency can also predispose one toward getting schizophrenia. When it comes to brain structure and function in schizophrenia, schizophrenics, when compared with non-schizophrenics, generally have been shown to have enlarged ventricles, smaller hippocampus. There's also cellular disorganization within the hippocampus. There is hypofrontality associated with negative symptoms. There is higher degree of brain symmetry relating to lower degrees of lateralization. There is also greater loss of gray matter during adolescence, like a forest fire, failure to produce sufficient synapses. On this slide, we look at enlarged lateral ventricles in schizophrenics. On this slide, we look at hypofrontality in a twin with schizophrenia. Schizophrenia is also associated with larger losses of gray matter in adolescents, and this cortical loss of gray matter appeared to be larger in girls than in boys. The biochemistry of schizophrenia, we have a famous dopamine hypothesis, which is imperfect. And this hypothesis motivates the use of typical antipsychotic medications, which are dopamine antagonists. The abuse of stimulant drugs can produce positive symptoms of schizophrenia. New forms of atypical antipsychotic medications, they act on serotonin systems, functioning as serotonin antagonists. There is also interaction between glutamate and dopamine activities or systems. Reduced glutamate activity may be tied with negative symptoms. Higher dopamine activity may be tied with positive symptoms. Treating schizophrenia. The treatment of schizophrenia was revolutionized with the use of typical antipsychotics, which are dopamine antagonists, in 1950s. However, they only reduce positive symptoms, and they can lead to tardive dyskinesia, slow involuntary movements. Recently, atypical antipsychotic medications, serotonin antagonists, are used. They are better in a way that they can reduce both positive and negative symptoms. There's also non-medical approaches such as psychosocial rehabilitation, which covers work, social skills training, education, better housing, etc. That's it. This is the end, and I thank everybody for taking this mod and going through all the struggles with me.